Welcome to the CME Essentials podcast, covering current topics in clinical medicine. The show helps clinicians stay up to date on the current standards of care and catch up with the latest clinical developments and trends. Each episode features a lively discussion between the physician host and a noted clinical expert. They dig into the issues practitioners face every day and provide insight on improving patient care.
Hello and welcome to another installment of Oakstone CME Essentials in Family Medicine. I am your host, Dr. Brandon Fainstad. I'm an outpatient general internist at the VA in Denver and an associate professor of medicine at the University of Colorado. I am thrilled to be teaming up with Oakstone to explore the evidence and best practices on topics most relevant to the care we provide. Today, I'm joined by Dr. Barak Gaster as we discuss a generalist approach to the diagnosis and management of dementia. Dr. Gaster is a professor of medicine in the Division of General Internal Medicine at the University of Washington in Seattle, where he serves as the director of the Cognition and Primary Care Program and is a co-investigator at the Alzheimer's Research Center. He is also the creator of the Dementia Directive, a widely used tool for navigating advanced care planning for dementia. Dr. Gaster is an expert and a true pioneer in methods to best equip providers, patients, and their families with the right structure and language to have the hardest and most meaningful conversations around this subject. I feel fortunate to have him here today, and I'm eager to learn as much as I can from him. Dr. Gaster, welcome.
Thanks so much, Brandon, and it's really a pleasure to be here.
Our discussion is divided into two parts. In part one, we'll discuss the current and anticipated impacts of dementia in primary care, practical tips for working up a memory concern, how to differentiate mild cognitive impairment from dementia, rule out confounding factors, and how to identify which of the common neurodegenerative diseases is the likely cause of dementia. In part two, we'll focus on evidence-based approaches to maintain brain health, medications both currently available and anticipated, then pivot to advanced care planning, including Dr. Gaster's Dementia Directive. We'll end each part with key take-home points. Before we dive in, Dr. Gaster, can you tell us a bit about your background, including your path to dementia care and what you and your colleagues are accomplishing with your Cognition in Primary Care program?
Yeah, absolutely. So I think the most important thing to say is that I am, in my heart, a primary care doctor. I've been a primary care doctor for about 20 years, and it was about 7 years ago that I realized that the thing I was struggling with the most, and I saw my colleagues around me struggling with the most, was dementia. So for about the last 7 years, I've really been focusing on becoming an expert on dementia in the primary care setting. And about 4 years ago, was able to get funding from the CDC to build a team to develop the Cognition Primary Care Program, which is really developed as a concise, easy lift quality improvement initiative to help primary care doctors know what they need to know about cognitive impairment, make a diagnosis of mild cognitive impairment or dementia, and then help patients and families navigate through the disease.
That's fantastic. I only hope to discover a project that is as inspiring for me as that has been for you and to turn it into actionable solutions. I'm thankful that's where you landed. Let's get started. Dementia is already a major issue for our patients and their families. Many studies project a significant rise in the disease burden over the coming decades. According to the WHO's 2018 report, dementia is the 7th leading cause of death. It affects approximately 50 million people worldwide, otherwise put 5% of the world's older population. And that number is expected to increase to 80 million in 2030 and 150 million in 2050. So over the next 25 years or so, tripling the number. The annual global cost of dementia is estimated to be about $800 billion US dollars, and nearly 85% of that cost is related to family and social care. This is estimated to increase to $3 trillion by 2030. Dr. Gaster, what else is noteworthy about the impacts of dementia?
What I would say is that as shocking and eye-opening as those numbers are, they don't really tell the true story of the emotional impact of this disease, patients and families, and on the doctors who care for them. It's really hard to understate the degree to which a diagnosis of Alzheimer's or related dementia, the very core of who somebody is, starts to fade away is really, really difficult and hard for everyone. And so I think really the important thing to say is how much this has such a giant impact on our lives and our emotions, and how much there is that we can do to actually make this a manageable and workable disease, both in the primary care setting and in society at large.
Yeah. Let's anchor our conversation on a case, making it a little more true to our own lived reality here. Let's hear from Dr. Lydia Calamari, an internist at Atrium Health in Charlotte, North Carolina.
Jack is a 68-year-old with a history of controlled hypertension who presents to clinic along with his wife with concerns about his memory. Gradually, over the past year, he has noticed he has difficulty recalling specific words and names, and he admits to missing a few appointments, despite being reminded by his wife. She also adds that he previously managed their finances, but this year became frustrated with himself when the process took at least twice as long as usual. He denies problems driving, though his wife reports he did get turned around along a routine route in town last week. Review of systems is negative for headaches, sleep issues, med changes, depressed mood, or recent life stressors. He is a retired electrical engineer, denies significant alcohol use, and is a never smoker. No family history of dementia. His exam is unremarkable with a blood pressure of 122/65, heart rate 65, alert, normal gait, no tremors, normal speech pattern, and cranial nerves are grossly intact. A CBC, TSH, B12 level, and non-contrast head CT are obtained and reviewed. All are normal. A Montreal Cognition Assessment, MoCA, is 23 out of 30. Does this mean I have dementia or Alzheimer's or something? He asks. How do you advise him, and how do you direct his care?
Okay, so it sounds like Jack's feeling limited in new ways, but only in his higher level functioning. He continues to be independent with his ADLs, and I was hoping, Dr. Gaster, you could help us break down the difference between normal aging, mild cognitive impairment or MCI, and dementia.
Yeah, and that is really the central area that is a source of so much confusion of how do those three things differ: normal aging, mild cognitive impairment, and dementia. How does that relate to Alzheimer's disease and related diseases, neurodegenerative diseases like that? And what does it all mean? And so the way that I frame it out for my patients and for the other doctors that I teach are that there's a continuum, which is really what somebody starts with normal aging. And it's absolutely typical that as people move into their 70s and 80s, that it sometimes takes them a little longer to come up with somebody's name, but then they do, or they may misplace their keys a little bit more often, but then they find them. That those are all normal changes with aging that really freak people out, but are not at all a sign of a neurodegenerative process. But then there is definitely a subset of people as they get older who develop more signs of what we would think of as neurodegeneration, where they are having trouble, especially with their short-term memory. They are having trouble completing complex tasks that used to be easy for them, or they're maybe getting disoriented in a place that they should know well. And those are all big worrisome signs that are more indicative of mild cognitive impairment, but somebody is still fully functional in terms of their activities of daily living. And so that's mild cognitive impairment. But then it's a spectrum that then for many people with mild cognitive impairment will go on over years to turn into dementia, in which people lose the independence with activities of daily living. And so that spectrum of people's functional status is overlaid on top of the various etiologies that can be the cause of neurodegenerative process like that, with Alzheimer's disease being the most common type.
So for a case like this, somebody that is so high functioning at baseline, but showing some decline in those higher level skills, those IADLs, how would you approach the evaluation of his impairment? And ultimately, how would you characterize it for he and his partner?
Yes. So Dr. Calamari has done a terrific job here. I think the most important thing is to have in your mind a checklist of the things that could be impairing somebody's cognition that might be in addition to a neurodegenerative process like Alzheimer's disease, or really the sole cause of their cognitive impairment. Dr. Calamari has done a great job in this workup, which is to think about the obvious blood tests that we all probably remember from medical school, like don't forget to check a TSH, don't forget to check a B12. Think about the possibility of depression. But then there are other really important things to consider, like excessive alcohol intake or untreated or undertreated sleep apnea, or somebody losing their hearing and not wearing a hearing aid. Those are all really, really concrete things that we can do in primary care to really make a difference in people's brain health. And so the first thing to do is to rule out other comorbidities that could really be impacting. And then just to make sure, just like Dr. Calamari did, to make sure that you're also doing a cognitive assessment. And the MoCA test, the Montreal Cognitive Assessment Test that she used, is an excellent one that can be done in the primary care setting and is much more accurate and better than the mini mental status exam, which we can talk about later. But then I would also really highlight how important it is to also make sure that you need to get input from an observer, like a close friend or a family member, that the world's best dementia experts have trouble really doing a fully comprehensive evaluation of somebody's cognition without having somebody there as an observer to report, give some history on how that person is navigating through the world. And that's something that we don't necessarily automatically have in primary care. And so that's the incredible value of having somebody return for a dedicated cognitive evaluation visit and bring a family member or close friend with them to that visit so that you can get some of that collateral information.
Yeah, that's a useful tip. I can definitely think of a few times I was evaluating a patient in isolation and really didn't feel like I had the right comparative information to know what was going on and what kind of decline was really happening.
Yeah. And just to speak a little bit more to the various tools that you can be used in the primary care setting to evaluate cognition, the MoCA test, the Montreal Cognitive Assessment Test, is the test that has been validated to have the best sensitivity and specificity to especially detecting mild cognitive impairment in the primary care setting. And so that is the test that I recommend the most. It's definitely not the be all and end all, and I'm really hopeful that within the next 3 to 5 years, we will have easy access to tests that are better than the MoCA. But for right now, that's what we've got. That's what I recommend using. But it's also the case that there are some practice settings in which you may have a lot of patients who have very, very low literacy. And this is not because of a language barrier, but somebody who has just never had any education at all, which is definitely a somewhat common situation if you're caring for people who have immigrated from other cultures, other countries. And in that situation, a test that is really worth taking a look at is called the RUDAS, RUDAS, which was actually developed in Australia for the Aboriginal population there. That it's not quite as well robustly validated as the MoCA test, but it really is designed to work well for somebody who has very, very low education level.
Yeah, I wasn't familiar with it, so I will reach for it if I ever end up in that situation. What can you tell us about the mini mental status exam?
Yeah, and that's the one, so when I was in medical school more years ago than I care to really calculate, that was held up as here's the test to do, just fold it into your physical exam. And the problem with the mini mental status exam is it's really pretty rudimentary in terms of its specificity and sensitivity. It was really validated much more for use in the hospital setting for inpatients, in which the overlay of delirium is a really big concern. And there have been really, really odd things that have happened to the holder of the copyright of that test over the years, such that technically the holders of that copyright have been really, really strict in trying to enforce that copyright, in which they actually demand a $2 payment to the company that owns that copyright anytime anybody theoretically does a mini mental status exam. And obviously that's not happening, but that is a relatively strong copyright claim that the owners of the mini mental status exam are making. Whereas the MoCA test is free to use without any copyright claim like that.
Well, aside from this case, just what's your practice with cognitive screening tests in your panel?
Yeah, and that's the big looming controversy. The United States Preventive Services Task Force is under a lot of pressure to reassess the recommendations that they have made for this in the past, in which they have not recommended doing an actual cognitive screening test as a screening test for all patients over 65 in the past, but they are under a lot of pressure to reevaluate that and rethink that with the newer FDA-approved drugs that we'll talk about later. And so we will get an update from them soon, which may or may not indicate a change in their recommendation. So my general practical approach to that question is, should we be giving everybody a cognitive test such as the mini-cog? So the mini-cog is the test that is most often used in that situation because it's a 3-minute screener. It doesn't have great sensitivity for mild cognitive impairment, but it's got pretty decent sensitivity for dementia. And goodness knows there are a shocking number of patients who are drifting through health systems with undiagnosed, unrecognized dementia. And so a mini-cog screening test can be useful for identifying patients like that, but it still leaves something to be desired as a screening test for mild cognitive impairment. And so I myself am kind of agnostic about whether to do screening tests like that or not. I'm definitely eager to see what the United States Preventive Services Task Force comes up with. And the main teaching point that I make is that regardless of whether we're giving everybody an actual test, we really do need to keep our radar up for worrisome concerns, signs, things that really should lead somebody to get a cognitive evaluation in addition to a positive screening test. One of the other really important points to make is, as most of the listeners are aware, Medicare requires that there be a quote unquote screen for cognition as part of a Medicare annual wellness visit. And, that's one of the 67 requirements for billing a Medicare annual wellness visit. And the way that most clinics will interpret that is asking a question on the annual wellness visit questionnaire of, do you or somebody who is with you have a concern about your thinking or your memory? And it's worth keeping the awareness of that question in itself is a screening test. I mean, it's a screen for cognitive impairment. And so, we're definitely never going to stop doing that. And I think one of the most important things that we can be doing in primary care is really to do a much better job when we get a yes to that question, to really take it seriously and understand what kind of questions should we be asking to, tell me more about that, so that we can really make a clear-cut and good medical decision about, is this somebody who really, really needs to have a cognitive evaluation?
Yeah, I like that. This is maybe one of the few instances that the Medicare annual wellness check is helping us make the right intervention, maybe even before it's time. Okay, so if we go back to the case, he had a surprisingly low MoCA score of 23 out of 30. So it's less than 27. Seems that he would fall into probably mild cognitive impairment. And only because he is so high functioning at baseline is he maybe still able to perform as well as he is. Am I thinking through that correctly, or how would you clarify it?
Absolutely. And this is a situation where you do really need to put a MoCA score into the context of somebody's previous functioning. And so this is somebody who was an engineer. And so the odds that this MoCA score of 23 out of 30 is a pretty dramatic change from his baseline is really, really high. And so the odds that he has mild cognitive impairment are extremely high, especially when we put that together with the history that his spouse has been able to give, that he is having trouble with a complex task and that he is missing appointments in a way that he never would have before. This is definitely a picture that is very, very consistent, and it is enough in the primary care setting to make a diagnosis of mild cognitive impairment. And that mild cognitive impairment very well and in all probability is early Alzheimer's disease. But it's just so important to also not lose sight of the other things that could be completely the cause of his cognitive impairment, but even more likely could be exacerbating whatever neurodegenerative process might be happening. And those are the things that checklist that I mentioned before, and it's just so important. I'm just going to sort of run through it again, which is your easy things of, rule out thyroid dysfunction, rule out B12 deficiency, but then really make sure you ask about alcohol intake, about sleep apnea, about hearing, and really taking a careful look at somebody's medication list, because the most important thing that a geriatrician ever taught me is just how important the medication list is when you're thinking about somebody's cognition, because medicines that might have been fine 10 years ago might be really impairing somebody's cognition as they're getting older. And the key ones are things like benzodiazepines. So somebody who maybe has been on a low dose of clonazepam for years and it's been fine. It's very possible that that dose of clonazepam is now really messing up with their cognitive function. But then it's really the anticholinergics that are the real sleepers here. And I say sleepers because they are sleepers because we miss them, but there are sleepers also because people take them as sleeping aids. So, things, especially over-the-counter sleeping aids that have diphenhydramine in them, will not be on your patient's medication list. You won't even know that they're taking them unless you ask them. But those are really medicines that can be impairing people's cognition. And they take medicines like that because they hear on the news that lack of sleep causes dementia. And so they take these sleeping aids to try to get the recommended hours of sleep, when in fact they're actually doing themselves tremendous harm, because the anticholinergic burden of diphenhydramine, which is like what's in Tylenol PM, is very, very high. And so making sure that you're asking about over-the-counter medications is absolutely essential in doing a good cognitive evaluation.
Yeah, never neglecting the beers list. What rules do you have for getting imaging, head CT or MRI?
Yeah, and this has definitely been in evolution since I finished medical school a long time ago, which is that, it used to be that like, oh, there's really not that much role for imaging, because it's true that most of the time imaging is not going to be helpful in this situation. But I think that the thing that has really changed in the last 10, 15 years is just the accessibility of CT scanning, the relatively low cost, the fastness of it has gotten so much better that it's really hard for anybody to walk into an ER anywhere, and especially if they're over age 65, and not get their head CT'd. And so getting a non-contrast head CT is absolutely an essential part of the workup, and it's recommended by the American Academy of Neurology. The question of whether that's enough imaging or what is the role of MRI is fuzzy. There's not a clear-cut answer. The actual recommendations from the American Academy of Neurology says do some imaging and are somewhat open to the question of whether it should be a non-contrast head CT or an MRI. An MRI, as everyone knows, does have a bit more detail to it. And, here what you're mostly looking for is just something sort of like really unusual or wacky a very rare cause of cognitive impairment, which, could be a brain tumor, especially if they are having changes in their gait and their urination, should lead someone to think about normal pressure hydrocephalus. And for most of those things, a non-contrast head CT is going to be an adequate screen, but doing an MRI to get a little bit more detail of the brain is not a wrong thing to do either.
It seems that you would get those basic lab workups and a non-con head CT in almost all cases, and really only reach for the brain MRI if there was something particularly suspicious. Is that about right?
That's right. Yeah.
Okay. I want to think a little bit about the dementia-associated conditions and how we start to differentiate between them. So now that we're quite confident that this is MCI without delirium or some other medical cause overlying it, how do you approach the consideration of these common dementia-associated conditions?
Yeah, and that's such a great question. It's the question that people ask the most of, well, what about the different types of dementia? And I think the most important point to make is that our ability to define a specific etiology in most patients is still pretty rudimentary. And most patients who have neurocognitive degeneration actually have a mixed form where there are features of both Alzheimer's disease and another cause for their degeneration. But for sure, Alzheimer's disease is by far the most common cause, the most common type, and short-term memory loss is the most common feature of Alzheimer's disease. Less common types or causes of cognitive degeneration leading to dementia are Lewy body disease and frontotemporal disease. The most important thing to say about Lewy body disease is that it can cause visual hallucinations and has really important management considerations in terms of the really severe reactions that people can have to antipsychotics. So anybody who's having visual hallucinations really should be referred to see a cognitive neurologist to get worked up for Lewy body disease. Frontotemporal disease is the most common form of dementia that occurs in people under age 65. And so it's important to say anybody who's developing severe cognitive impairment below age 65 absolutely needs to see a cognitive neurologist quickly. And then the vascular disease category is really pretty complicated in that it relatively rarely exists completely on its own, but is the most common etiology that is perhaps coexisting with Alzheimer's disease as a form of dementia.
Yeah, and it seems that that's only going to be a bigger and bigger representation of dementia as we move forward and metabolic syndrome becomes a bigger issue in our society. One last question I had is, when would you consider referring a patient with dementia to neurology for additional evaluation?
Yeah, and so that's also a really good question. The answer to that question has changed in the last year or two because with the new FDA-approved drugs for mild cognitive impairment due to Alzheimer's disease, which we're going to talk about next time, it's important to at least have in your mind some familiarity with those drugs and some sort of space in your counseling patients of, this drug does exist, and if you are interested in learning more about it, we should be referring you right away. But otherwise, the main big red flags that should absolutely prompt a more urgent referral are people who do have visual hallucinations, in which case Lewy body disease is a really important consideration with real practical management implications. And so somebody with visual hallucinations should really be referred to a neurologist. Anybody who has rapid progression or onset of cognitive impairment, so in less than 6 months, really should see a neurologist. Anybody who's developing cognitive impairment below age 65 really should see a neurologist. But in most cases, there is less urgency, and it is really okay to have shared decision making where the primary care doctor can be doing so much to improve brain health that we're going to be talking about in the next part that, it's okay if it takes them a year or two or maybe more to eventually see a neurologist.
Great, that's useful. Okay, let's wrap it up with some take-home points. First, the validated cognitive assessment tools. MoCA is the best validated for detecting mild cognitive impairment in primary care, but for most patients with extremely low literacy, consider the RUDIS RUDAS. And MMSE takes less time, but may miss MCI. Next one is rule out confounding factors. These are all the standard tests that we like to order in our initial workup: CBC, TSH, B12, and getting a non-con head CT in almost all instances with consideration of MRI of the brain when there is something suspicious. Don't forget to consider alcohol, sleep apnea, and review all harmful medications, especially over-the-counter medications that you may not be aware your patient is taking. In distinguishing between the different neurocognitive diseases associated with dementia, Alzheimer's disease is by far the most common and predominantly memory loss after age 65. Frontotemporal dementia is the one most commonly presenting under 65, often associated with behavioral and language changes. Lewy body disease will present often with visual hallucinations, and vascular associated dementia has a stepwise decline with associated risk factors. In consideration of when to refer to a neurologist, all patients with visual hallucinations, considering the additional care measures that may be needed, rapid progression, presentation under 65, and those that may have candidacy for novel interventions.
The opinions expressed are those of the reviewers, authors, and commentators and do not necessarily represent the views of Oakstone Publishing. Please review the complete prescribing information of specific drugs or combinations of drugs, including indications, contraindications, warnings, and adverse effects before administering pharmacologic therapy. Thanks for listening to CME Essentials in Hospital Medicine. To learn more, visit oakstone.com.